Okay, welcome everyone. And let's get rid of that. Welcome colleagues on the screen. So we have quite a few apologies today. I think that's a reflection of half term, more than our board meeting. We normally get a pretty good attendance. So rather than read out the list, I understand Phil has just said he's on holiday as well.
Oh, okay.
All right, so we're going to be compact and bijou today. So let's press on. So we're going to start with an extraordinary board meeting to begin with for the Devon board meeting. So this is most specifically aimed at those colleagues around the table who are the statutory board members for the ICB for Devon. Welcome to you all. We're going to have to go through the declarations of interest. Happy for you to note the declarations of interest? Yeah. Very good. Thank you. So there's a lot in here. Hopefully this is going to be, rather than going through every single policy, etc., hopefully you're all sighted on the level of detail and you're comfortable with the work the executive group have put forward, and you've done that. In terms of the cluster corporate governance framework review, Philip, is there anything you want to do to introduce that?
Yes, thank you. So this is a piece of work that will be familiar to the board and in particular to the Audit and Risk Committee members. It was something that was proposed to audit and agreed by Audit and Risk Committee members at the end of last year, and is something that we propose should be completed on an annual basis going forward. It's good practice to make sure that the governance frameworks that we have in place make sense at least annually. Obviously there may be opportunities to review and revise as we go through the year so that we can remain as agile as appropriate in terms of governance. As you say, John, it's a big hefty pack, and that's the reason why it's being brought to both ICB boards this morning, because this is part of the core corporate governance roles of a board to ensure that it is happy with the content of the governance framework. I'm not proposing to go through the detail of the packs themselves, because I think they are, as you say, that they will have been well reviewed by audit committee members and by board members. They've been circulated well in advance of the meeting. I think the important thing to note is that we've done a good piece of work, I think, with our internal audit colleagues. So this is as a result of their review, their comments and the work of the corporate governance team to get the best possible set of policies and processes in place that make sense across both organisations, so that we really enable us to work as a single cluster rather than having, for example, a different conflicts of interest policy in one versus another. So I think that's probably as much as is worth going into at this point, and obviously happy to answer any detailed questions that anybody might have.
Okay, any questions? Graham?
Now that we have a single executive and a cluster arrangement for the ICB as an organisation, are we clear where in the governance its plan, I know it's developing a business plan, where will that sit in terms of committees? Because historically, Devon FPQ and its predecessor would be looking at the delivery of its plan. Where will that be in the new structure, please?
So this is the South West Peninsula Management Board. The terms of reference are included in the pack, and that reports directly to the South West Peninsula Board. And so that would be the route through which that oversight would be maintained and reporting.
Happy with that? Yep. Lovely. Thank you. This is effectively working towards the options for us merging as we go forward. As you say, Graham, we've got a line, non-execs, executive starting. We'll soon be moving into the wider sense of wider staffing, and the governance stuff is aligning. Yeah.
Yes, and I think effectively this puts us in a place that, from a governance perspective, means that should the board decide that it wishes to, the two boards decide that they wish to merge, that we're effectively there from the governance perspective. I do think it's important to reflect on the fact that these do, whilst stability is important and annual review is important, that we do need to keep certain aspects of the documents under review as well. A good example would be the equality, diversity, inclusion statements that are at the beginning of each of the policies. These are fairly vanilla statements at this point in time, I think I would say. And I think it's something that I'm sure, I know our customer experience and equity committee would want to have a look at as part of the overarching perspectives in terms of what we're looking to achieve in terms of EDI across the cluster. So I would anticipate that these would evolve over time, and that would look to that would be entirely appropriate and worked on our public sector equality duty responsibilities as well.
Okay. Very good. Frank?
I made the point on Tuesday, but just because this is a formal board, I'd like to make the point again that a lot of the governance structures that are in place are for what we have at this point in time, and they're very light on primary care involvement in all of those. I know there are plans for it to happen, but there have been plans for it to happen for 5 years.
That's a good challenge.
Yes, thank you. So these structures are very much focused on the way in which the ICB itself controls itself, the systems and processes in place within the ICB. So that is why they're very heavy in terms of ICB executives and non-executives. As you say, we are working on a separate piece of work, and I think I see it in two halves, which brings us out across the rest of the system. One, which is the systems and processes that we need to put in place to work better with our NHS colleagues, and the other is the systems and process that we need to put in place to work better with our local authority colleagues. And as you say, work is ongoing, and we have a conversation in our private meeting of the South West Peninsula Board this afternoon to discuss the NHS side of that, and we will have an integrated care partnership workshop next week, which we can discuss the local authority side of that. So I would anticipate that we will be bringing proposals for formalising those arrangements to the June board meeting of the South West Peninsula Board, or the July, depending on how those conversations go.
And just to state the formalities of it, in the direction of moving towards a merger at some point, there'll have to be formal stakeholder engagement anyway, and that'll be the opportunity to unpack any of that before we get to April. Okay? All right? I'm not going to read out. We'll be here until lunchtime, this. So there are a couple of actions in here. One is to take satisfactory from the processes of the advisory review. I'll pause at that point. Are you happy to take that satisfactory assurance? Yeah. And the second one is take satisfactory assurance the proposed amendments to the core elements. And then that element, are you happy to take satisfactory assurance from that? Yeah, thank you. And agree the proposed changes to the following corporate governance framework documents as listed in this particular document. Are you happy for that? Yep. Agreed?
Just to add my thanks to internal audit colleagues, as I've mentioned already, and to the governance team who have been working incredibly hard on all of this work during an incredibly stressed period of time as we go through the organisational change associated with the clustering. I think personally I wanted to reflect that.
Yeah, and thank you to you also, and the team, and teams for doing that. It's an immense amount of work and preparation work. Okay, so we've agreed all of those. Is there any other business? No, in which case I'd like to close the public extraordinary board meeting for Devon. Just need to seek some advice. Do we need to come off this link and go to the next one? Happy to stay on this link?
No, I think we're on the same.
I'm back, just come down to observe the meeting.
Welcome everyone back in the room.
But thanks for introducing yourself, Chris. That's I good manners and confidence.
We're good to go? Okay. Everyone, thank you. So welcome to the Cornwall and Isles of Scilly Extraordinary Board meeting. In this particular instance, now you're in the room, welcome Robert, formally again, as one of our new non-execs. I think we'll take the absence as they were beforehand, so it's quite straightforward. Are there any declarations of interest? No? Okay, so over to you, Philippa, to introduce this paper, please.
Thank you. The paper sets out proposed amendments to the corporate governance framework for the Cornwall and Isles of Scilly Integrated Care Board for 26-27. It's a mirror of a paper that has been presented to the Integrated Care Board for Devon earlier this morning. I will just repeat some of the points that I made earlier, just for the sake of ensuring that they're in the minutes for this meeting as well. This is a piece of work that was undertaken by internal audit colleagues and the corporate governance team. We discussed with the Audit and Risk Committee the remit of the review and the proposed approach to it, and we have been providing the Audit and Risk Committee with information throughout the time of the review. We also had an opportunity to discuss the proposed outcomes of the review, the meeting of the South West Peninsula Board in private last month. Essentially, this sets out the policies that need to be had in terms of core corporate governance policies. We're framing them as joint policies across both integrated care boards. It refreshes the terms of reference and other key corporate governance documents. I think this is to say it's important that we do this at least once a year. Doesn't mean that we should only do it once a year, and that we, as we experience and work through our new working arrangements, we may want to revise our corporate governance frameworks as we go through that. I think key point that I would bring across is that there will still be work ongoing in this space throughout the year as well, particularly in relation to the equality, diversity and inclusion statements that are included within the joint policies. These will be reviewed by our People, Customer Experience and Equity Committee to make sure that they move forward from the reasonably vanilla statements that we have currently. I think those are probably the key points that I need to raise in relation to this report.
So, colleagues, this is for the Cornwall and Isles of Scilly board members, of course. Any thoughts, questions, clarification? Okay, so bearing in mind we did have a conversation during the Devon board meeting, unless there's anything else that's coming out from any of the colleagues who have joined us from the Cornwall board. Cornwall and Isles of Scilly board? No? Okay, so one of the things that I need to say here also is thank you to you and the team, Philippa, for a huge amount of work here. This is, of course, bringing together, we've already brought together the cluster non-execs, we've brought together the executive team, we're in the process of bringing together the wider cohorts of executives across the two ICBs. But this is also bringing together our governance work across the two ICBs that will help facilitate any future merger and will make things on that journey slightly slicker and smoother. That doesn't say we can't revisit this, it's just that this is doing a huge bit of heavy lifting to get it much closer to be able to facilitate that. Yes?
I think it's probably worth flagging. We had a specific conversation in the Devon meeting about the representation of primary care and VCSE and other partners in our structures. I think it's worth reiterating in this meeting that this paper deals with the ICB structures. Work is ongoing in relation to system structures required across both Devon and Cornwall. That's where we will see more information being brought through to the South West Peninsula Board in the future in relation to our ways of working with our local authority colleagues and with our other NHS colleagues as well. So I think it's just to put a marker there that will be coming in the next couple of board meetings.
Thank you. And Graham, is there any value in you just asking your question again?
Yes, in the Devon equivalent meeting, I noted that what used to happen was that the equivalent of Finance Performance and Quality Committee would receive a monthly paper that would report on the delivery of the ICB's plan. I know that we are developing a single plan for the clustered ICB, and I was now questioning, since it is a single organisation, whereas it was previously a Cornwall and a Devon, where would that now sit in terms of governance? And just to follow on from the answer that I got last time, but I'm sure you want to build upon it, the significance to me was that I think under the previous system there was a non-exec involvement before it got to board, but under these proposals it won't be seen in its entirety until it gets to board.
Okay.
Yes, so just to respond to that, so yes, that is the case. The South West Peninsula Management Board, which is an executive group, is a formal subcommittee of the South West Peninsula Board under these proposals, and excuse me. The proposal is that we would split out the objectives of the business plan for the cluster to allocate each to a particular committee, so that there will still be non-executive oversight, but it will be at the board where the view of the whole plan is reported.
Okay, thank you for clarifying that. I'm going to move to the recommendations in a second. Just before I do, we have member of the public. Welcome.
Thank you very much
John
indeed.
Gavett, I'm the chair of the
Thank
board.
you for the welcome that you
That's
gave.
right, thank you. Is there anything you would like to ask based on the agenda item we have?
No, I think I just want to listen today. Really, thanks very much, and thanks for the opportunity to do
Lovely.
so.
All right, okay. Thank you. In which case, I'm not going to read everything out again, but I'll go through the recommendations. So the first one is to take satisfactory assurance from the process of the advisory review on the effectiveness of, etc., etc., etc. Have a read of that. Everybody happy with that? Yep, thank you. Moving to the next one, which is taking satisfactory assurance that the proposed amendments to the core elements of the Cornwall and Outer Scilly, etc. Are you happy with that? Second one? Yep, everyone's nodding. Thank you very much. And finally, to agree the proposed changes of the following corporate governance framework documents. I won't read them out, but as listed in the paper. Everybody happy with that? Very good. Excellent. Thank you. These are the kind of board meetings I like. Is there any other business? In which case, I will close the board meeting now. And for those of you who are on the call, we have a public board meeting starting at 11 o'clock, so I'm going to hand you back 20 minutes. Thank you very much, everyone. Let's leave it there. Thank you. Welcome everyone, it's 11 o'clock, let's get started. So, welcome to the South West Peninsula Board meeting in public. Welcome to those of you in the room and online, and to some of the colleagues in the public area. Welcome. My introduction is going to be a couple more introductions in terms of people. Robert, welcome again. But this is our first public meeting that we've had. Robert has joined us as a non-exec director, a huge background and experience in a variety of areas, and was formerly on the Torbay Trust board as well. So, welcome. Some of you might know this next bit of information, but Rachel's online. So, Rachel has been with us since the cluster started as the representative from NHS region. And of course, I've known Rachel for a lot longer than that when you sat on our Cornwall and our Sicily ICB. So Rachel, thank you for everything you've done for us in your role at region. But just so everyone knows, Rachel is actually joining us from, not next week, I think it's the week after. And you will become the transformation director for Devon. There is a team already earmarked to be part of that. I know that's got a few little processes to go through, but I look towards Chris, who's standing in as Mark's away on holiday, acting chief executive, and hopefully, Simon, you feel that we can get this through all the necessary processes such that there's agreement on that. So welcome, Rachel. Thank you for everything, and welcome from when you start. In terms of apologies, because it's half term, there are a number of people who are on holiday. I appreciate that. As I said earlier on, that's no reflection of our board meeting. But what good value for money we are. This is our third board meeting of the day. It's only just 11 o'clock. So as we move on, just to say that Anne-Marie will be joining us on screen, but she has another meeting that conflicts with this at 11 o'clock. So if you see her pop on the screen, that's because she's slightly delayed. So let's move on to declarations of interest. Anything to declare? No? Okay, thank you. Minutes of the previous meeting held in public on the 26th of March. Any areas for factual correction? No? Good, thank you very much. Philippa, can you help us on the action log, please?
Yes, apologies. Sorry, I'm having some technical issues. Bear with me. So, as ever, we have a number of actions that are proposed to close and a number of actions which remain open. I'm not proposing to go through the detail of those which we're proposing to close unless anybody's got any particular concerns in relation to those. So that would be my first question. I'm not seeing any hands raised. So, in terms of the actions which remain in progress, we have a number where updates have been requested. Excuse me. In particular, I would go to colleagues to see whether they can share any updates at this point in time. The first one is in relation to contract management annual plan, finance and quality discussion that took place at the end of last year. Where there was an action to write out to members of the board in relation to setting up the CPAG arrangements. I believe that this is probably going to be encapsulated in work that we're doing around system governance in relation to working with our local authorities and working with NHS partners. But I go to Susan and to Chris if they want to add anything to that update.
Thanks, Philippa. No, nothing to add. I think it's a piece of work that we need to conclude as we go through and you know the new structure and understand how exactly and explicitly what we need the CPAG and how it needs to function. So I think it'll iterate and change, but we just need to make sure we have, I think, clarity of where the clinical input sits in relation to the governance structure. So it's a piece of work that I think will fall out over the next few weeks, as you say, as we embed the current model. I don't know, Peter and I, did you have anything else to add? You need to switch it on.
No, we discussed the mitigation in the meantime, which is that we have in Devon the clinical leadership group and you have the neighbourhood development group that has clinical representative, which we are using to understand the work that is currently in train, and that we have a clinical understanding and input into that.
Thank you. The second item, which is still in progress, this is a piece of work that's being undertaken in the governance team. It's not due until September, so I'm not proposing to give any more of an update on that. And then the final item is one that was previously allocated to Penny Smith, and we will be following up with the appropriate lead for this going forward, so we'll have an update at the next meeting.
Yep, Martin.
I mean, given that came from our committee, this was around, I think, good experience to do with MAID events in Cornwall pre-Christmas, and I would say, you know, the action was to try and share learning with the Devon colleagues, but given there was so much sharing in the integrated and neighbourhood health space, including the recent conference, bringing some of that together, I'd be surprised if the learning hadn't already been shared, if you like. Personally, I'd be comfortable to close it because it's just a bit historical.
Let's close it down. Yep. Anything else? No, thank you. Let's move on. So we're moving on to patient vignettes. So hopefully you've all had a chance to look at the videos online. They're quite, they're all inspiring normally, but there's a few ones that really touch your heart and inspire you in this particular story. Any thoughts you want to start with? Frank?
I think they're all brilliant. They are exemplars of neighbourhood working. The thing that really struck me was the Devon ones do not mention the word neighbourhood, but all the Cornwall ones do. And the ones in Devon are just as good as the ones in Cornwall. And we haven't quite got our act together in terms of the new terminology and promoting ourselves, but there's lots of good things happening in Devon. The other thing, the word that really struck me was kindness. And that's what is written through all of those vignettes. Both kindness towards people who are working, but especially kindness towards the people who are getting the help. And if I was to say one thing that will change the way we interact with the whole population is if we put kindness front and centre of everything we do, we will end up in a better place.
Okay, agreed. Yeah.
I was very struck, as Frank says, by the work going on in Plymouth, Ilfracombe, and there was one phrase that stuck for me, was really important to think about in everything that we do, and that was when one of the recipients said, asking for help is a big step. And I think facilitating people to ask for help and advocacy for people negotiating the health and care system is going to be a really important part of neighbourhood work. And I was also struck by the illustrations of how difficult in North Devon it is to manage just to travel on a bus to attend a job centre and to attend appointments. And I think it's easy to forget that. In terms of the neighbourhood health engagement models that we saw, particularly the Cobra Valley one, what didn't come across there in that particular presentation was the cost of the development being, Chris, can you correct me, is it something like 4 times what would normally be, 4 times less than is normally spent on such a development through usual contracts with the NHS? And I think that was a really important lesson. But the medical, the social model that's being built, it's almost becoming the social model we need with the medical model attached to it. And I think that's something we need to remember all the time in what we're doing.
Right. Thank you. Let's bring in Stuart.
Thanks, Chair. So I just wanted to, having been part of one of the neighbourhood health engagement events, I just wanted to commend Lucy and her team for what a brilliant job that they did with those events. I've done a number of public engagement events over the years, and that was comfortably not only the best attended, but the most diverse, reaching events I've done, so that there were hard to reach groups, and there were young people, children, and of course the people who we usually see from our PPGs and so on. So Lucy deserves a great deal of credit, and the team for pulling those together. And the other thing that struck me with the event was the vibrancy came because actually neighbourhood health really resonated with the people who attended. It was palpable that the movement to a more preventative agenda and a move to care closer to home really resonated with the population. So I think it was a really brilliant event in St Austell. I know that that's the same feedback we've had elsewhere, and I just want to also just sort of further the importance of continuing with public engagement as we go through the neighbourhood health programme.
Thank you. Chris?
I just don't want to miss the opportunity to build on that, to thank Lucy and the team, but Stuart highlighted the continuous engagement as part of a neighbourhood health and care model is critical, and the expectation is, as neighbourhood teams mature, that continuous engagement is done through them themselves, i.e. they become less and less reliant on Lucy and the team, but I'm sure Lucy is always happy to support. But remember, the whole point as we mature, that's the role of the neighbourhood teams themselves to bed that in as business as usual. It's critical.
Thank you. Graham?
Thank you. Yes, I'd just like to highlight the Help Force Back to Health vignette that we've got here. I know this board's discussed, as it were, the return on investment on neighbourhoods, and I know there was a discussion around what that ratio should be and how much should you measure it and what the methodology should be. So with all of those sort of caveats, nevertheless, I think it was really interesting to look at that as an example of 11.6 million, and I know it also comes up in your chief executive report as well, but I think it's just worth highlighting that it just does demonstrate that you can debate the exact number, but there's undoubtedly a return from that shift. Thank you.
Okay, so I'll try and move us on. I too want to say congratulations. I know you've been doing these sort of vignettes for a little while, but I think this is just really at the crescendo point of really beginning to have an impact on the way in which we think here. And as this is a public board meeting, I'm just not quite sure whether we've shared this publicly or not, but the way in which we're going to move, and I know that Libby and I are meeting with Lucy and Town, you're going to come along with your hat on as well, is we'll continue these patient vignettes, videos in the public session. But as we start to move into the other sessions each month private, we're going to start to actually bring much more of a patient or customer experience into the room. And then that's thinking about quite how the customer journeys are going, the touch points that people have with us, not just in the acutes. This is really the important point here, because a lot of this is way before you get to that point. It's actually in neighbourhood and community. And we're going to be driven by neighbourhood plans. They're going to be written into the work. It's a shame that we haven't got the health bill decided yet, because in the new NHS modernisation health bill, it starts to make it very clear the way in which which we're doing anyway, but really need to become an exemplar of the way in which we work with local authorities, to actually build as part of those new initiatives, how we're going to actually build from the bottom up, from our neighbourhoods up through until each area. And I want to build on something that Frank's talked about earlier on, which is there's something about neighbourhood needs to be mentioned more in Devon, and in some ways I think we need to start not talking Cornwall, not starting in Devon, but actually talking about Cornwall and Devon, the way in which this works. So I know that we've spoken offline about this, Chris, about we do need, because we're structured this way at the moment, but as we start to move into more about place-based activity, then I think it's more about how do we do place that shines through in here. So if you can think about how, with Lucy, some of the place-based thinking starts to weave into not just this meeting, but future meetings, and then how we bring in the local authorities and primary care, etc., into that left shift. I think we need to make those much more about how we drive left shift going forward. Is that all right with you, Chris, as a direction of travel? Okay. Peter, while I'm on this bit, the other bit that came out for me on here is, and it'll be in the forward plan when we get to talk about it, is how we're leveraging population health management and evidence more. it's great having these as reminding us why we're here and the impact that we could have. But then we need to scale some of this stuff. And I think if we can start leveraging with Lucy how it's feeding into your population health stuff, and then how we start to drive outcomes from some of this, I think that'd be really helpful. Neil reminded me nearly 3 or 4 years ago the importance of using this evidence. And I just think we've got to bring more evidence into the room using this mechanism. Does that work for you, Peter?
Yes, absolutely. I'm working with colleagues in public health to understand the needs of our population, and to the point, patient vignettes, even if we look into our communities, don't represent those people who live in our communities who are currently healthy or who may not be accessing services. So thinking about that through the lens of population health is really important. And I would agree, bringing the data to boards to inform that discussion, really important part of the work that we're doing.
And, you know, Lincoln, I think it's important that we ensure that has gone through a route through you first, in some ways, to make sure that we're, you know, public health directorates of local authorities are fully engaged in that before it gets to this position. Una?
Yeah, I think it's important from the point of view of identifying and targeting our population, but also the other side of population health management is about the evidence base of what we're actually providing in our healthcare and the consistency of the delivery of it. So that is another really important thing that we need to work closely together on, is making sure the evidence is all out there. It's just actually using what's out there in a more structured and organised way to provide that quality and consistency.
I know this is a strange segue, but this is the way sometimes my mind works. But because of the modernisation health bill that's coming, and because we've got to increasingly move stuff into the communities, we've got to start having the evidence base to be able to convince some of our provider partners, most specifically, about not just talking about it and doing what I call the veneer of it, but actually really committing to move at scale, pace. And that evidence is going to be so key. So Chris, I'm going to lean on you too a bit here, because we've captured a lot of evidence across Cornwall and Devon now, and we've got to start bringing it into conversation. And Neil challenged us earlier on about looking towards next year already. And there's something about bringing the evidence to bear now that would actually ensure that the evidence is in place, laid down, such that when we come to do planning for next year, it can be driven by the patient that we need and we're focused on, that drives the finances, but actually is targeted.
Thank you. I think there's a role for the board in actually agreeing what the system priorities and outcomes are.
Okay.
Is that from at a local level, a lot of providers will look at things from their perspective. If we're wanting to shift a whole chain for the Peninsula, is the board agreeing what the clinical outcomes and priorities are, and then using the population health intelligence to map that down into how that looks at neighbourhoods to help then in targeting the work. And that will give the best evidence outcome and seeing results to meet the challenges, both from health outcomes and financial pressures as well for the system.
That's a really helpful contribution, because Lucy, where I wanted to finish this, if it's all right with you, is that over the last few years, we've touched on a variety of different things in these patient vignettes. When we look towards the private board meeting as well, I'm just wondering whether if I could get the board's support for actually getting the executive group just to reaffirm the priorities, and then focusing on some of these things on those priorities. So actually constantly bringing the top priorities to bear in our boardroom. Does that work for everyone as an approach? Yeah, you happy with that?
Yeah, I think that will give much more of that intelligence-led and seeing those outcomes, and also sticking to those in the acute parts. The other thing is that when we have our usual winter pressures that we see, is keeping those priorities in line as well, so that we actually don't lose our attention to those as well.
Yeah. Yeah, okay. Lucy, anything else you want to add?
Just a thank you to everyone who featured in those films and made possible. And if you do have any ideas or initiatives, please do reach out. Just the other point I wanted to make is that we are attracting a lot of national attention for our neighbourhood work, and so we are going to be at the NHS Awards in a couple of weeks' time, so it would be really great to see if we can bring a win back to the cluster. Thank you.
Good luck. Good luck. Okay. At a time when the national team are in the process of appointing a national patient experience director. So this is perfect timing for us to leverage the thing that we were doing before it was invented. Okay. Okay, let's move on. So well done. Thank you for that and full support. But you're clear on the kind of themes structure that we want to move to, focusing on the priorities for our top area. Okay, let's move on. So my chair's report. So little game I thought I'd deliberately put in here, which is, could you see where I made a deliberate mistake? Okay, it's not called Barnstable Hospital. So it's in Barnstable, the hospital. So if we'd be kind enough to correct it and give it its proper title, I'd be very pleased, Helen, if you could do that. Yeah. Thank you very much. And we'll correct. There's another slight error that was in there which I hadn't spotted. But if you could upload then the correction to that as it was pointed out to me helpfully. All right. The things that I would like to share with you on that is when I made the visit to the hospital in Barnstable, I have to say, if you haven't been there, you need to go. It's an impressive place. The chair and chief executive that look after walked me around that with the clinical teams. It's way bigger than I thought it was. A lot more infrastructure there, but it reminded me of Cornwall. It took me about 4.5 days to drive there, and the next thing is that it's really interesting for me how it took me back quite a few years. I'm going to be honest with you. It took me back a few years because there's something about Barnstable and its catchment area is rooted in very dispersed small communities, difficult transport and that kind of thing. And if ever you wanted another classic example of doing neighbourhood activity, should be rather than investing in more and more into Barnstable's hospital, to me it'd actually be thinking, with the problems you've got, how do we keep it in communities? Because it's really tough for those communities to get there. So if you haven't been there, I suggest that that you do go and take a look at it. I really wanted to thank Sian and Sam for walking me around there. Other thing I wanted to really touch on, because we're going to touch on it later on in the day, I didn't go into as much detail as I will later on in the day, but the King's speech is thrown down as a bit of a gauntlet in terms of the modernisation health bill. Again, I think we as a cluster board are ahead of the curve, but it has implications for us in terms of the way in which we go about commissioning, the way in which region and NHSE work with us, which will come on to as the day goes on, but also the way in which we work with local authorities. And I think it's increasingly important that we don't wait for the legislation. I think we actually see where the legislation is going and start to just do good practice and work to it anyway. So if there's anything on my bit on the King's speech and the legislation you want to tease out, there is a lot more that's in the wider board pack and private later that we've had some legal advice on in terms of what it means, because we're also, if you think about the extraordinary board meeting we had in public earlier on, one for Devon and one for Cornwall, and the Silly, is that we're aligning things because we're starting to get ready and getting our minds around merging potentially from April 2027. And if that's the case, if you're looking at the forward plan, we'll be looking to see it probably in July when we come to think about how we're going to do that. And then a lot of that will actually have an impact on formally having to go out to consult with stakeholders as we go through that journey and to make sure that we get to an April 2027 position where we can consider, well, not consider, but if we've made the decision in July, we'll be going for it or not in July. But how we're going to set ourselves up. But there's lots of issues that I'm afraid to say everybody needs to have all parts of the jigsaw before you form a view. I'm sensitive at the moment that some colleagues are reading a particular article and go, well, that's what I've heard. I go, yeah, you might be right, but you need this part of the jigsaw, you need this part of the jigsaw. So if I could just ask you as we go through this, let's stay tight on this, and if you have questions, please put them forward. But there's a lot in there that's going to impact on the way in which we work and our core purpose. I thought I'd just raise that with you. And I'll let the executive team talk about the phase 1 work. Phase 2 work that's going on. But thank you to the non-execs. I just want to shout out to the non-execs. As we're now beginning to be clearer on our places, we've now aligned a non-exec to each of our places. And I understand the executive group, which I've written in here, I think I've got the right list. The list changed around a bit. That is the right list. We now have lead executives for each place. And one of the challenges we'll be picking up as we go forward over the next few days and weeks, particularly when Mark's back, is what empowerment those individuals actually have to be able to work with each place. Because these are the colleagues we'll be going to health and wellbeing boards, be going to the places, talking to the key leaders in each area, and coming with an exec and non-exec leadership. I think we should actually get some real support behind the way in which we as an ICB work. Happy with that?
Yeah.
Okay. Anything you want to ask me on that, or else we can pick it up now? No. Yep. Yeah.
Thank you. I'm really pleased to hear you talking about the challenges of rural areas from your visit to Barnstable. because this is something we've talked about imbued in a lot across Cornwall, a lot of ways. I think it's really worth having, and Chris will have heard this before, like a stuck record, is that actually the model of care and actually developing a workforce tomorrow and pivoting into rural healthcare and that style of things. I think it came from whenever Justin Varney Bennett came out to the islands as well. There is learning from places like in Australia and outback medicine, and we've been talking for quite some time. Do we need to actually be talking as an ICB and partners with the schools in Plymouth and Exeter about looking at the model of what they teach and actually pivoting into rural healthcare across not just medics but the whole workforce, and actually starting to create a model of skills that is better suited to the rurality and the challenges, but also that shift into community as well. And, you know, it would be an investment in the future sustainability of the workforce that would be better suited to our ageing population as well as a rural one.
Yes, please.
It's probably, Ewan knows that's music to my ears, because we've talked about this a lot, because I think as we talk about, you know, transforming our model of care from the traditional hospital-centric to a neighboured health and care model, we need to not just think about the estates and what we need, but the workforce as well. So that new way of working and taking into account communities, rurality, deprivation, and actually more of a teamwork approach. Actually, yeah, the sooner we can bed that into actually how we are training the next generation, that becomes quite exciting. And I think Ewan and I have pointed out that the Southwest Peninsula is a perfect location to really try and drive that. And so I would welcome that, Ewan. And so maybe we just agreed that we try and get some momentum into that conversation to make it real. Yeah.
Where will you do that? Because I think we're only agreeing with you, but how do we get some traction on that?
We can do it from the Cornwall perspective. I'm happy to talk about it from a Cornwall perspective, to try and start conversations with Exeter and Plymouth.
Happy with that? Would you be kind enough to lead?
Yeah.
Yep. Ewan's happy to lead on that. Great. Well done. Excellent. Anything else on mine? Yep, Peter?
Yeah, I just wanted to shout out on the same point, if it's okay, John, for the Health Innovation Network, who is running an event next Friday around coastal and rural health, which should bring the conversation such as this, but the things that we can do that will facilitate new models of care that are right for our population, not necessarily for populations of other metropolitan areas. So it's joining all of those dots together and making sure we have a coherent programme, I think.
Very good. Frank?
One of the significant challenges to us moving to community working and neighbourhood working is the constant request for return on investment. So thank you very much, Chair, for highlighting the community health and wellbeing workers' return on investment as £2.3 for every pound invested. I'd sort of like to question it the other way round. What is the return on investment for our present mode of working that has been proven for us to continue doing that? I don't think there is one, and I think there is lots and lots of evidence, both nationally and internationally, that return on investment for community working and working in the way Union has been suggesting in communities out in rural areas is significant. So it's just to highlight the constant demand for proof of return on investment. We probably don't need to do it all the time. We need to believe it's the right way to go.
So let me ask it in a broader kind of way. As I raised earlier on the question about evidence, population health, how do we bring more of the left shift evidence into this room such that we can see the magnitude that challenges our own commissioning thinking? Libya, does that fit within your bag, in Peter's? Where does that fit? Yeah, Peter?
So for me, I think the concept of moving towards a better intelligence centre where we triangulate and bring together the expertise in health economics, public health and population health data, and our old style performance and commissioning data into one space and triangulate and understand it is the way that we answer Frank's question about how do we understand the allocative arrangements now for where the money sits, and how do we shift it from where we are now to where the most need is in our population, and we do it differently through the models of care and fund.
Okay, Louis?
Yeah, and alongside that, one of the key things we've just talked about is the people insights, so the insights from our communities alongside that data and hard sort of evidence. So it's all of that in the round. So Peter's role and my role worked intrinsically together, really, around those data and insights.
So when we get to the point where we talk about the forward plan, would you be kind of just to remind me in case I forget, there is a timeline for a population health strategy coming back here, and it's not going to be that far away before we start planning the commissioning intentions for the next. I just think we need to be ahead of the curve. So that's all. I know you want it to be evidence-based, but I'd like it to be pre-run through here. Does that work for you? Okay. Should we move on? Yep. Diane?
Sorry, just from a VCS perspective, I think there are two things that I'd really like to highlight here. One is this whole idea of rural proofing for everything and anything that we are thinking about in terms of planning development. So we're really clear. We think a lot, I think, about equality proofing generally, but rural proofing isn't always something that we have thought about strategically, and we probably need to do more of that. And then the other issue is the fact that when we decide on our forward planning and our commissioning rounds, we always look at the data we have in front of us. And the challenge with that is that we don't always have the VCSE data in front of us, obviously. So if I could just put a plea in for some really extra work to think about how we're going to bring in that evidence from the vignettes and from some of the other things, the social investment, which isn't sitting within the NHS general data sets. And that's going to take a little bit of extra work and effort, which I think would be worth putting in if we're going to come out with the outcomes we need to.
Okay. Peter?
Just to let you know that work is in train, and actually I can't remember her name, forgive me, but somebody who Joe probably, yes, so really helpful. Our engagement, it was Julia, yeah, our engagement event was where we had that conversation, joined it up, the work is already in train.
So she's the deputy
Okay.
chair.
Oh, I didn't know that. Okay, all right. Ewan?
I would suggest that this should all be feeding into the joint strategic needs assessments for the areas and what the requirements of those are in informing, as we're going to committee in common next week, and they're informing the sort of the plans and the strategies. Sure. So it's working with local partners on a consistent sort of observatory of that sort of data is something that we need to look at.
Yeah. Don't prolong it too long. We're just taking on Frank's point. This theme of rural. So when I was in Barnstable at the hospital, I asked the question, why don't people travel from here to Exeter as a hospital? Oh, the infrastructure's not good enough. So is the infrastructure from their communities to this hospital in place? No. Well, how do they get here then? So there's something here about all roads lead to doing it in their own communities, kind of thing, and that's what we've got to particularly scale up. Okay, I know we all know that, but we've got to move on from the language now, I guess. Right, let's move on from mine, if that's all right. Thank you. We move to the Chief Executive's report, which standing in for Mark. Would you kindly do it, please?
Yeah, thank you, Chair. So yes, I'm standing in for Mark whilst he's on holiday. So I'll take the report as read, but if I just pull out some points I think I would want to note is obviously there's a real emphasis on organisational change and concluding that part of our phase 2, our restructuring. So that needs to happen at the earliest opportunity. We recognise that because we recognise that the stress that puts on the staff whilst we're going through the process. I was going to mention the exec leads in place, and so that's been covered. And then noting the impact on staff, turning it the other way around, the fact that there's 7 NHS Excellence Awards regional. We're waiting to see if they're national winners, one of which is neighbourhood. I'll say now before Stuart and GP colleagues remind me that the neighbourhood award is not about CFT. CFT are the hosts of neighbourhood. The neighbourhood is very much being driven by primary care and the voluntary sector and multiple providers. So it's a whole team effort that I think gave rise to that award, which is excellent news. I'm just cognizant we've got members of the public from Plymouth, and then the teams were diffusing bombs while still keeping GP access and other things open. So again, it just shows you the resilience of our workforce. We talked already about engagement because there's a nice Isles of Scilly engagement. Some of the colleagues, Libby, Lucy, you were at that. Again, just the importance of that and listening to people in their patch. So we talk about rurality. I think the Isles of Scilly is a extreme example. And then obviously, I was just going to raise. We mentioned neighbourhood health centres. So. The Truro Health Park and how that's progressing, because that's in an early part of the funding for a neighbourhood health centre on buildings that are already in place. But we have done a preliminary return to NHS England on the potential of neighbourhood health centres across the southwest. But we do need to reflect that we can't just think about it in a traditional urban-centric model, going back to rural proofing, and that some of our neighbourhood health centres might take on quite a sort of innovative type approach, sort of a campus type approach, and trying to think about flexible use of spaces. But that is part of where our thinking needs to be. And that's all I wanted to say in terms of. I'm happy to take any questions.
Yeah, thank you.
Yeah, I just wanted to highlight the section on antimicrobial resistance, and really pleased to see a focus on that. Local authorities are doing quite a lot in that space alongside the clinical work that the NHS would be leading. We have raised before the concern, particularly around capacity in community infection control, which is part and parcel of this. Multi-drug resistant TB, for example, is one of the few things that will keep me up at night. Because when you have one of those cases, the implications are so challenging to manage them in the community. So we really welcome that focus, and particularly that third bullet point about strengthening clinical capacity, infection prevention and control, particularly in the community, working with our care homes, etc., and that diagnostic stewardship and how we can work with you from a local authority perspective as well.
Okay. Happy to move on. Graham?
Thank you. Truro Health Park, I believe there's private sector involvement in that development. And if that's the case, are there some lessons to be learned? Because I know we're talking an awful lot just now about workforce, but there is an estates implication. We know that capital is very restricted. We know it takes a long time to secure, etc. But am I right in thinking there's been private sector involvement in that, and how could we scale that potentially? Thank you.
So there's the nuance to how I answer that. So the buildings owned by community health partnerships, which is what's a LiftCo building. Community Health Partnerships is a company, but it's owned by the Department of Health and Social Care. So there is part. So they get part private. So in effect, we deal with the Community Health Partnership as the company, and I think they get some of their investment through the private sector, but obviously some directly from government as well. That's a unique case in the sense that they had got money early to specifically look at their buildings, what's called LiftCo buildings. So there was only a certain amount of building opportunities that we could use that potential investment for, of which the only one identified in Cornwall was Truro Health Park. So the second part I mentioned, the sort of the return we've recently done on the neighbourhood health centre opportunities, I think is about where we might see private investment, government investment, or other forms of investment. And of course, it links to Helston Cobra Valley, which is where we had the Healthcare and Select Committee come. One of the visits they did when they were down in Cornwall was specifically to look at that, because again, that's another way of funding buildings, which is worked out very, very cost effective through a community interest company. So I think the way forward is to look at all opportunities, including the private sector.
Neil?
When initiatives developed in rural areas, and certainly I can remember early diagnostic centres coming in from the private sector and having to have raising grants about the fact that they had based themselves 400 yards from the nearest bus stop with no car park and no ability for people to get there. I really hope that access for people, particularly people needing to use public transport, will be front and centre of anything that we look at in terms of neighbourhood health centres.
Yeah, I totally agree. And I think obviously what we know is that there's nothing at all committed when it comes to neighbourhood health centres. This is going to have to be a piece of work that is done in collaboration with not just general practice, but secondary care, but voluntary sector, local authorities for exactly the reasons you've just highlighted, yeah.
Thank you. Fiona?
Thank you. I'm really pleased to see the report focusing in on neighbourhoods and neighbourhood health. It would be remiss of me not to mention, it says in there about place-based budgets evolving over time. From a Cornwall perspective, we're really interested to know what that will mean for Cornwall and the place as well, and not eroding resources and allocations.
Bit of a hint. Well, you've seen what we've committed to for this year and for next year. I think if the National Chief Executive of NHS was in the room, I think 2% of our budget would be like an entry discussion. And if you want to do 2% of 1.5 billion, you can do the maths. No. And that's why I keep positively replying in terms of... and that's the challenge, scaling this up. They can't keep doing this at the level we're doing it. Tom?
Yeah, I'm really interested in the focus on rural neighbourhoods and really what we're talking about here is about helping people to access services earlier. Because if they don't, it has a knock-on effect for them, but it also has a knock-on effect for our system, because people get sicker and then need to go to be conveyed in ambulances to mainstream, to big hospitals, which we know doesn't give them the right outcome and we know is expensive for our systems. So all of these different lenses that we look at is about how we sense make within our system. Let's be honest with ourselves. At some point, we're going to we have a finite envelope, and at some points, we are going to have to start to make some difficult decisions about where we spend our money. Mm-hmm. My vote every time would be to look where we can at a neighbourhood first approach.
And we're caught in that cycle of demand is driving it up, and yet you need the left shift to stop the demand, but we can't afford to invest in the demand. The left shift, so we've got to find a cycle of breaking that. You know, final word on this.
Also, really advocate for a life course approach. As you know, Start Well, Live Well, Age Well is working well, and in that upstreaming, the earlier we invest in our younger people, and we do have a tendency to often focus on our frail elderly. It's important that we actually do the whole life course approach as well to help with that long-term demand management.
And when we talk to our Devon colleagues next week at the ICP, is that writ large, the life course, in your paper?
It's a joint paper with Chris. My focus is on governance, but I think from my recollection that we are also talking about the life course as well, but Chris probably better answer that one.
I think it needs to be.
Yeah, the short answer is yes.
Because if people don't understand what that means, is it's the start well, live well, age well. But this is where it's so pivotal in terms of getting the local authorities and the NHS to work together. They are co-chaired. It's not just the badges of life courses, it's the integrated working. Is that fair, you know, in terms of an alley?
Yes, I often have to take account for things when I would rather not as well. You know,
Yeah.
So it does work in having that joint ownership, and it is partnership working.
It is.
It is very
Thank
much
you.
so.
Rachel?
Yeah, just very briefly, there's the opportunity obviously also exists where the ICB from next April will take over the commissioning of public health. So the totality of the population budget and therefore the kind of whole totality of commissioning around the life course. So that should also play into conversations in preparation for that as well, because there's shadow commissioning at the moment.
Yeah, I haven't quite worked. That's what I mean about all the bolts of the jigsaw. Exactly right.
Yeah, I just wanted to sort of make the point that I think it was really interesting, Neil's comments and Eunan's comments around the importance of aligning different organisations, their different priorities around the same outcome. So life course Obviously, the investment up front is often less in health and more in education and frailty is about the response to ageing. And I think having a mechanism for us to be able to align and understand each other's priorities through a committee in common or some such vehicle is a really important way of actually translating words into action, which I know, Chair, you're particularly keen on.
Very good. Okay, thank you for your report on that. Let's move on. So I'm just looking at the clock, so I'm going to do this slightly differently. By exception, we'll take everything as read. By exception, I'm going to go through. Are there any partner members who would actually like to raise any standout issues from their board reports? I'll do it by exception. No partner members? No. Are there any non-execs who would like to do a standout? No. Is there anybody else who would like to have a standout? Graham?
I think you're embracing quite a lot of papers here, I hope, because my question is, I noted that RCHT has paused e-care implementation. I know we've had a discussion before about what it might do to performance metrics. And elsewhere, I saw that TSD went live with Epic during Easter. So how have we made a decision in one place to continue and in one place to halt? What's the logic about that, please?
I was going to say I would look from Rob, and I can see Robin's on the call. He might be able to give us the clarity.
Yeah, well, I can see that Stuart's got his hand up first, so let's go to Stuart first and then Robin.
Why don't you let Robin answer that specific question, right. Chair, because mine's a different topic.
Oh, okay, thank you. Robin, on this particular point?
Thank you. So our pause was, we've gone through a gateway process of a 90-day go, no-go and a 60-day go, no-go mechanism. And at our 60-day go, no-go mechanism, we weren't ready for a go-live. So our pause isn't because we're doing something different to Devon, is we're following the same methodology of that assessment of, are you ready for the safe go-live? At that point in time, we didn't pass that gateway. So there's more work required for us in partnership with Oracle, our provider, to get the EPR ready for rollout. So it's not because we're doing something different to Devon. Every trust does that same go, no-go criteria selection process, and that's what we did, but we uncovered elements that we need to resolve into.
Did that answer your question?
Well, I'm just making sure that the reason we've delayed isn't for impact on performance, because we've debated that one before.
Definitely not. No, it's because we weren't ready for the go live of the product.
Okay, Frank.
Sorry, I should have got my act together slightly quicker and said something regarding their primary care report and the GP report. I think the two important things to highlight is the GP CIC is still progressing very well and should come into being. It is the equivalent of Kerno CIC, and that will be across Devon. The primary care CIC, which is general practice, dentistry, optometry, pharmacy, and the VCSE, is also poised to go, but not identified the funding to do so at this point in time. The reason I think a primary care CIC is vital is whenever we're having the organogram discussions about, governance and all the rest of it, that is a way of having primary care thought of as an entity. The other thing is, I don't think it's going to be very easy to commission without that in place. You can't strategically commission primary care through a GPCIC on its own, I don't believe. So I think it is quite important that we do create that entity.
Okay. Stuart?
Yeah, thanks. So I just wanted to pull out and update the risk of collective action in general practice to the board. So Frank's paper actually is more articulate than the Cornish one on collective action. But so just to put all this into context, the GPC have consulted general practice on the latest contractors' concerns around unfettered online access and the contractual obligation to provide same-day services for everybody who needs it. And the general practice has voted in favour of collective action. So what that means in Cornwall at the moment is 12 practices have formally written to say that they're going to remove their data sharing agreement from the 1st of June. The next phase is planned to be targeting switching off Optimize RX, which is the technology that optimizes the formulary and the prescribing to make it as cost effective as possible. We know that had significant financial implications the last time that happened. But I've just been informed by our LMC chair that today the GPC is announcing a ballot to general practice to potentially offer or explore a different contracting mechanism to the current NHS contract, which will be means tested and partially privatised, similar to the way that dentistry's provided. Obviously, there's a lot of water to go under the bridge about that. But it is, that the things are escalating, and it's just to sort of update the board on that, and that it's a genuine risk. In Cornwall, we've had a very pragmatic approach to collective action in the past, and I hope that continues. And that's, I think, because of a great working relationship with our primary care team, but also with the LMC on the inside of our collaborative board. But nonetheless, this does feel like a genuine risk to particularly leadership of INTs, which we know that there's a desire for general practice to be at the heart of that. And actually, at our collaborative board away day last week, our GP leads unanimously stated that they want to lead provide the clinical leadership in our INTs. So just an update for the board really on the collective action.
Thank you, Peter. Anything you want to add?
We are working from a data sharing and understanding the implications of that, and responding to GP colleagues who have sent those letters along with Kirsty, our Director of Primary Care. So we have a process to understand and respond and understand the risks and the implications in the longer term.
All right.
Emphasising the point that Stuart said, the implications, the impact of this, which is why we've got a task and finish group led through primary care and the digital team. Is we don't want it to derail the sort of the neighbourhood approach, but it does expose, in my opinion, how the way we commission healthcare in general is is in a completely different orbit to how we want to ultimately deliver neighbourhood health and care, where we talk about integrated services. So it's a really good example of just showing the amount of work we need to do when we look at how we want to ultimately strategic commission a neighbourhood health model when we've got this sort of situation arising.
Okay.
Sorry, John. One last point is, I think, given that this is a meeting in public, it's really important to say that we are working together with our colleagues in primary care to make sure that this collective action around data sharing agreements doesn't impact directly on patient care, which is not the intention of the collective action.
Very good. Thank you. I just want to come back to Frank, if I may. You raised some questions in your report and some observations. We talked about collective action, but you talked about the CIC also, and you wanted clarity on the financial support. Where is that being considered, even if it's a no? There needs to be a view on that. So where is that being taken and by who?
So I think it needs to be a joint consideration between I'm looking at Libby and Simon in terms of what does it mean, and obviously working with Frank and colleagues and understanding kind of the principle of having primary care at the table in terms of real clarity of governance is I think a given. The best way to bring that to the table, I think, is the discussion that we just need to land, and maybe how do we take examples of what's already working well? How do we in effect piggyback on Kerno CIC, which is Frank's alluded to, but not lose the fact that we need primary care in the room. So it's an active conversation right
So
now.
if you could take that away, because I'm conscious of the fact that we're trying to end up with a break-even situation. And if that's the case, we're already struggling to identify all the funding to get to that. And here is another pressure. So I just think we need to be transparent in this. Work together by all means, but please be transparent in terms of that. Just going through your list, you're requesting pharmacy contract is ring fence for community pharmacy development going forward. Libby, how do you want to respond to that on another day? In Frank's report, it talks about pharmacy contracts, ring fencing, and community pharmacy development going forward. Do you want to take that offline? And,
If that's okay, Chair.
Yeah.
Thank you.
I've established it's a slightly bigger issue since I wrote the report, in that there's various parts of primary care funding that was underspent that is now supporting our financial position. So it does mean that potentially primary care is not getting the funding that was allocated to it in the first place. That money could be used for the future for neighbourhoods or back to primary care. The reason I raise it is some of the pharmacies are going out of business at this point in time because funding is becoming chronically slightly underfunded.
So I think it's a question that warrants an answer. I'm not asking you, Libby, to answer it now, but if you'd be so kind to take it away and come back to Frank, so to be clear on that. And your question on optometry, Frank, do you want to just articulate that?
So the optometrists believe they can have a solution to quite a lot of the outpatient work. I have since found out that although they didn't know about it, there is a group looking at this to see whether a lot of outpatient work could move directly out into the communities and be done through optometrists. Obviously, that would require quite a significant change in contracts, but would be absolutely in line with using the total healthcare provision and doing things more locally for people.
Happy with that?
Absolutely, it's certainly areas as part of the commissioning intentions that we're looking at anyway, Chair, so we can...
Thank you. I think in the mental health area, it was lots of noting going on. Sorry, yeah?
Discussion about the mental health paper.
Of course.
Please. For Cornwall, I think, being candid, that the capacity gap is quite significant and it doesn't seem to shift. As you're aware, in Cornwall and Committee in Common and Council, mental health is an area of significant concern. I think what's in the content of this paper doesn't provide assurance. It stimulates discussion, but I think actually I would be more comfortable if we have more detail of the plans to actually address this area, because mental health is supposed to have the same parity as physical health. We see the impact on workforce and everything else as well. The number of out-of-area placements, and that's not just for Cornwall, that's for Devon as well. There are long-standing issues in the mental health arena which are not being addressed in this report. It's acknowledging them, but I'm not seeing enough evidence as to what we're actually doing to make a difference.
You're particularly referring to Cornwall here?
Sorry?
You're particularly referring to Cornwall?
Yes, I'm talking from Cornwall perspective, but I'm welcoming views from Devon as well, because I'm sure...
Yeah, no, that's why I'm just picking up to know who to ask first. Adi?
Yeah, and Ewan, you're right, that's exactly what the paper sets out. It sets out the gaps. There is a paper later that talks about the first steps in terms of addressing those. It doesn't go into the level of detail you're after, and we can bring that back. This was a partner update, effectively, on where we are, and then when we come on to the next paper,
let's
maybe
note
have a
it
wider
and
discussion.
we'll come back on it. Substantive point?
So the mental health paper is really good, but it's reporting on what we know we do as opposed to what the gap is. There is a huge gap between SMI and TalkWorks, which is talking therapies, and that is where most mental health sits at the moment, and nothing is commissioned in that space. So there is a subsequent paper or evidence paper in the supporting pack, which I thought was excellent, But in some of that, it was saying, well, if the Community Mental Health Trust can concentrate on the seriously mentally ill, that'll be it, and everything else can move to neighbourhoods, then that'll be fine. The trouble is, neighbourhoods are having to take a huge burden without the resource. The community mental health resource was to move the stuff into the community, not to just concentrate on SMI. So the whole thing needs a proper discussion and analysis, please.
Libby, particularly, will you take that away? So if we could just note for Libby to take that away. The only other one, unless anyone wants to shout me down, I need to raise is the, as Lopa's not here, but Graham, maybe you could help, is on the is the Audit Chair Assurance Committee, where we're asking to approve the internal audit charter for Devon and for Cornwall. Do you want to pick up on that? Martin?
Yeah,
Do you want to help?
I mean, I was at the meeting. This was approved by the Audit Committee itself. I don't think it's necessarily a board approval thing. And these things were pretty standard in terms of how the really the Audit Committee relates to the work of the internal auditors. And we were content with it, John.
Thank you.
Yeah, I think just to add to, so I think it does formally require board approval, unfortunately, which is why it's presented as part of the report, but there's no reason for the conversation that took place at the Audit Committee for the board not
Lovely.
to.
So we just, thank you. Lovely, great clarity. That's why we've done it. Can I move us on, everyone? Nothing else? Just by exception? A lot to get through today. Okay, so where are we at on the committees? Out of area placements. Let's move on to that, please. So, Susan, you're leading on this. Where's Susan? There are some.
Thank you. So this might answer some of the queries that you've raised, Union, but it won't answer all of them. So just as a reminder, some time ago in Cornwall, we recognised that there was a significant harm coming to particularly elderly patients who were spending longer than they needed to in hospital. So we ran a rapid quality review, and it was quite apparent that during that work we were not spending enough time and effort in mental health and LDA. So this is a spin-off from that piece of work where we ran a very successful workshop that specifically looked at mental health. One of the outcomes of that is we need to do something more specific around neurodivergent type conditions that needs a lot of work. And I think that's fair to say that's as equal for Devon as it is for Cornwall from the time that I've been in this cluster arrangement. So we pulled together a workshop, and I have to say thank you to CFT, to the Community Trust, and to Colin, who's the new medical director, who really drove this work. In the paper, it's very clear that we have tackled the out-of-area placements, because you're right, Ewan, it's been quite shameful, really, that we don't have the facilities within Cornwall and the Isles of Scilly for lots of really good reasons. Money always is part of that reason. So we have had to use out-of-area placements. Unfortunately, that has really been because of our single-sex accommodation rules and regulations within the NHS. We find that there's been more women have had to be put in out-of-area placements, and we are cognizant of the fact that for some of those women, they are young and have families, and have had to go to fairly distant providers for that care. And we also are very aware that we have longer lengths of stay for people that are out of area. So as part of the restructuring that we're doing with the ICB, we have lobbied hard that we continue to have our clinical advisors and oversights where we can send to the providers that are out of area to ensure that we, A, can set eyes on the providers, we know what the services they're providing, that we're getting good value for money in terms of the care that the individual is getting, they're being treated with dignity and respect, and there's a clear plan to exit them, to bring them back to Cornwall and the Isles of Scilly. So out-of-area placements remain a problem. The work that we've done through the commissioning intentions and the planning round was quite clear that we should divert the funding that we spend to put into the direct control of CFT, which is the sum that's quoted in here of 3.6 million. They are much closer to the work, but we still have responsibilities as an ICB to ensure the oversight and the assurance of those people that we place in out-of-area placements. What we have said, and it's along the parity of esteem that we apply to people with general health, is that in the same way we don't want people who have various conditions that end up in acute trust because of reasons we've discussed many times at board, we should take the same zero tolerance to people with mental health conditions. We shouldn't wait for them to hit a crisis where they need a bed, and that's where the neighbourhood frank is so important. But I completely agree with you. We can't just ask neighbourhoods to pick this up without the infrastructure, without the skill sets. I have to say our voluntary colleagues have been phenomenal in this space in picking up some of this work. However, we do need to make sure that we are supporting them in the same way our local authority colleagues as well have been very good in this space. This is a system issue that we all have to own and own equally, and not wait for somebody to need a bed. And that's what this paper really started, and the workshop started to tease out. So if we can put in and invest correctly in talking therapies, invest correctly in all of those other mental health, and we know that to date what we've done is we've put non-recurrent funding into areas like neurodiversity for diagnosis. It doesn't work. We need to be very committed to recurrent funding that allows us to bring down waiting lists, that allows us to keep people out of institutional beds where we know that sometimes the issues that they face don't improve as quickly as we would like. So the paper outlines where we have those gaps, and we do have them in some of those serious mental health illnesses. If we do have institutionalised care, if we do have bedded care, we need to make sure they, in the same way we do for the acute trusts, our acute trust should be for people who need intensive care or the risk of needing intensive care or high dependency or surgery. If people aren't needing any of those services, why would we put them into an acute trust? The same should apply to mental health conditions, so that those people going in are those that need that care most of all. Anything else, we should get as close to people's homes and their communities as we possibly can, but be really clear that we put our money where our mouth is. We put the skills and competencies into those neighbourhoods. So I am very clear that mental health and LDA has got to be one of our priorities. And this paper, if you read it, it does need more detail, and I will hold my hands up talking to the authors. We've done it quickly to bring it back to here. There is something about the equity in here, about women, that we have not picked out. We need to put a bit more involvement into there. The life course, really important, Union, because we know that if a child goes into some of our mental health, they are labelled for life, and it's very difficult for them to get out of it. And we know that children who are diagnosed with neurodiverse conditions, sorry, I'm competing with the A team here.
You are the A team. You're part of the A team, for goodness sake.
Sorry, I'll just let him stop.
Sorry, everyone. This is for those of you who don't know, that's the sandwich van outside.
Right, I'll try again. Thank you. It would only happen to me, wouldn't it? So children that we know that children are neurodiverse or have neurodivergent conditions are often, when we look at the justice system, we see children have ended up in the justice system because we have not met their needs quickly enough. Equally, children that are sitting on waiting lists for neurodiversity, actually it's not the children, it's the parents that need the support. So this paper brings together a whole range of issues that we need to unpick, and I have to say this is quite exciting if you look at some of the issues that are within this paper. So I take on board Union's criticisms, or not challenges, not criticisms to be fair, challenges. But I would say, Chair, we do need to attack this as a system and not just as health.
Okay. Let's still listen to Adi first.
Yeah, and so echoing that, and this is the strategic intention. The detail isn't there yet, but it's probably the first time, Union, that they've actually expressed where the gaps are and been clear across the whole of mental health rather than treating it as separate services. Now, this is years behind what we've done around the urgent care pathways or the physical health pathways and neighbourhood health. So it's a step in the right direction. You know, if we had all of the funding in the world, you'd make some of those changes a lot quicker than what would, you know, than what's expressed within the paper. I think this is the first step, and just to add to Susan there, it wasn't just a CFT thing. This was voluntary sector, a local authority, etc., will around the table for this, for Cornwall. Yeah.
So you're going to talk to us about the issues in Devon in a second too, are you? Or?
That was not down for me to discuss.
No, but okay, I'll come back to it. So we're going to go Tarn and then Neil.
So mine's a yes and to all of this, and it's a further challenge really, and that's to understand the impact of repeating and intergenerational cycles of trauma and the role that they play in neurodiversity and in mental health, particularly when we look at children who experience those. It's not all equal. It doesn't just happen equally. While it's impacts on everyone, there are predictable prevention work that we should be doing in this space. And the more that we can work alongside the local authorities to identify those children, those families, the better our investment will be.
Bill?
A question and an observation. It used to be the case that when we discussed long stay for mental health patients and difficulty repatriating, that housing issues for people were a fairly constant problem. Is that still the case?
I think there are a number of areas. Some of it is the supported housing. So I think the paper starts to look at that as well in terms of it's not just going back. It's the whole pathway. Yeah. So including discharge and back to best place.
And just to make an observation about the neighbourhood health issue, I agree it needs support and development, but I hope that where there have been exemplars of good neighbourhood health building around non-traditional models, and one example is Trelia in West Cornwall, that these exemplars are taken as, and the lessons already being learnt are taken as a way forward for building proactive early intervention neighbourhood health models.
Thank you. Ali and then Martin.
Yeah, thanks, Chair. Just wanted to come in on the housing challenge, really, and just remind the board that we've got a supported specialist accommodation strategy, and actually really positively, I know that we've got a pipeline of supported accommodation for people with mental health issues, which is coming online imminently. Thanks.
Very good. That was good to know. Martin.
Hi, John. Yeah, happy to support the 3.6 million shift of funding, I suppose it is, rather than investment in terms of out-of-area placements. I just wondered, obviously it says in the paper, I think, subject to a trajectory being described, but just to get a feel for that, is the expectation here that this will meet our target of 0 out-of-area placements, and over what sort of time frame by the end of the year, what are we actually aspiring to?
So it's absolutely the objective, Martin. That's what we have to work towards, a zero tolerance. There will be, until we get to that point, it's going to take time to be able to do that because of the issues that we've had within CFT in terms of building property issues, which is what sparked this in the first place.
I suppose how much time to get to the trajectory then, if not to the final point, next month or?
Yeah, great question.
So we had submitted a trajectory that we think is achievable that gets us to 5 at the end of March 27. We've got to, again, I think we said before the end of the summer, we need a proper trajectory that gets us as close to 0 as possible. There are other bits to talk around, particularly in terms of interactions with Devon.
I totally understand the nuances, but just so we can have something to, see the investment flow through into.
Yeah. So just building on Martin's point, Susan, can I just ask, in 8 pages, great articulation of the problem. Yeah. There is a recommendation, the 3.6 million. I've no idea whether the 3.6 million is scratching the surface or cracking the problem from it, though.
So this is the money that's allocated to it at this point that we're spending. Yeah. So what we need to do is, if the money goes across to CFT, the expectation is also that we see a development further up so that we reduce the amount of out-of-area placements.
So that one paragraph that asks for this out-of-area placement shift, how much of the other 7 pages would actually say that it'll deal with all of
that? Not a huge amount on the other bits, and that's the point in terms of the strategic direction and the investment.
Right, which is your point.
It's the future years investment plan, and where things will be invested in and where they won't be.
Where they won't be.
So are we challenging ourselves via Libby's good office to actually look towards the future. This is this year. What this is actually saying is it's a great place to start. We've got to scale the problem. Can't do any more in a year, but actually the gauntlet is laid down. We now need to start ramping it up. Is that what I'm hearing? That's your understanding of it?
That's my understanding, absolutely.
Are you comfortable with that? Does that work for you?
Yeah, absolutely. This initially, John, was to solve an issue of out-of-area placement.
No, that's fine. Lincoln?
I just wanted to support that investment. Again, the prevention piece, the issue around young people. We are, as local authorities, sending in our SEND reform plans. This is a wonderful opportunity of making sure we are joined up on the prevention piece, given all that we've said about issues in young people. It is even more catastrophic when they have to be placed out of area. And we've all talked about where there are children involved with families, how disruptive that whole process becomes.
Okay, so let's move towards the, thank you, Lincoln. Let's move towards the recommendations here. But just before we do, this is between an observation to Peter and Susan. It talks about the key population insights again. Lots of words. As we start to move towards evidence kind of thing, I think we could do, particularly with a few more crunchy numbers. I rather rudely joked earlier on about, thank you some of the colleagues who came back on my appraisal, which thank you for doing that. But one of them was we need to see more numbers, more evidence, more scale, more trajectory in our numbers, in our papers. They're quite word-orientated. Is that a fair challenge?
Absolutely. And just to reiterate, we wanted to bring this back because we'd had the workshop. We promised board that we would bring back the outcomes of the board. But you're absolutely right. It needs further work.
Thank you.
Very aware.
Last word, lady.
The data's there, actually. Column's done a fantastic job in terms of understanding the prevalence and the information behind it. So it shouldn't take much to get that in. Yeah,
no, that's very good. I think we just need to see it, that's all. Okay, very good. So let's move to the recommendations. We're noting the key population insights. We're approving the strategic direction to shift the investment towards prevention, neighbourhoods and models and relapse reduction. Yeah. We're endorsing the priority actions and next steps, and we're approving the recommendation for the delegation of the 3.6 million out-of-area placement budgets to CFT, basically, subject to the agreed governance and reporting arrangements and clear outcome measures and performance expectations. Is everybody happy with that? Very good. Thank you, Susan. You have what you need there. Thank you. So we're moving on to the Board Assurance Framework, Philippa.
Thank you. So this is the first presentation to the South West Peninsula Board of a shared board assurance framework across Devon and Cornwall. We've adopted the approach where we have the same risks for each ICB. There are different risk ratings according to each ICB. So, for example, there will be some risk which have got a higher rating in Cornwall than in Devon, but they're all presented in the same place. I'm not proposing to go into a great level of detail at this point in time, other than to highlight the fact that there are some proposed amendments to points of detail across the board assurance framework in terms of who owns what risk, the detail of the drafting of risks and so on. This is the first iteration. This will continue to be a live document throughout the year. I'm very conscious that we're missing information in relation to one particular risk, and that will be worked on as well. The work that we've talked about previously at this board in terms of developing a business plan across the cluster will also inform the work that goes into this, so that there will be a much more detailed worked up iteration of this presented to the next meeting of the board, and that will continue as we go through the year.
Where will we see that business plan, please?
At the next meeting of the board.
The next meeting or the next public one? The next.
So we're due to bring a draft to the meeting of the board in June.
Lovely, thank you.
And then I anticipate that there'll be a final iteration brought to the board meeting in public in July for approval.
Perfect. Thank you very much indeed. Any questions, Graham?
Thanks. The delivery of constitutional standards and recovery priorities has changed director, and the score is awaited both in Devon and Cornwall, I guess, in the future for the cluster. Just help me explain that to me, because I would assume that we would know what it was in the prior year. Why isn't that our starting position? I'm sure there's some logic there, but Be helpful to share that, please.
I would need to direct you to our Chief Finance Officer for that because we're awaiting the information for it. So the governance team holds the ring on the on the presentation of information, but we require the leads to share the information as they're the ones that own the risks. So I can't give you the detail of that, I'm afraid.
Any help, Simon?
Yeah, we've come back with a response. There has been a debate about. Yeah, there's been a discussion about how performance gets reported through what route, etc. So that's probably what's held it up a bit. But I'll make sure you get a formal report on it.
And will this help advisors on performance in terms of the triangle between provider, ICB and region, given where we're going? Will that cover that area?
Yes, it will.
Yeah. And when will that come back?
Yeah, crucially, it will, yes.
And that'll come next month, will it? Or? Yep. We could just make a note of that. I think of all the things that.
Yeah, we're focusing primarily on that triangulation because it just needs to do it properly.
Yeah.
Thank you. Yes, absolutely.
Thank you. Anything else you want? Frank?
I'm very aware that it's part of the BAF, but I just wonder whether the whole neighbourhood theme needs to be a separate risk, because it is the main model for the future, and I'm not sure we are yet sure we can land it at the speed and scale that it needs to be landed. It's in reconfiguration, service change and all the rest of it, but does that give it enough focus would be my question.
It's a good challenge.
And I think it depends on your school of thought. So I think for me, there's neighbourhoods is a manner through which we will achieve our outcomes, and the BAF is focused on the outcomes that we wish to achieve. That's why neighbourhoods run through each of the risks. So you've got it woven through that way. If you were there to focus on particular deliverables, so ways of working, we might want to have other things in the BAF as well. I think one of the things we just need to think about is trying to keep it as manageable as possible, but open to the views of the board on that.
Thoughts? No? Graham?
Well, there is a strong case for it, I have to say, without which you might not get the visibility.
Well, I'll tell you what, feed it into flip it offline, because not everyone's rushing to support Frank's observation there. I think for the unitary board, I can see the merit in it. But.
And it may be that we can come to some compromise where we're much stronger in terms of provider and system alignment, because that feels like that's the space in which we would be wanting to major on neighbourhood. So we can have that conversation outside.
Very good. Okay, that's done. Lovely. So, any other thoughts on this? If not, I'll move to the recommendations. Very good. So we're endorsing the proposed risk appetite. We're approving the content of the latest iteration for the Cornwall Algecilia Assurance Framework, and we're approving the content of the latest iteration for the Devon Board Assurance Framework. Yep. Are we happy? Done. Thank you very much, Philippa, for that. So, now, we haven't given ourselves very much time for a couple of really important areas, so I'm just trying to get a little bit ahead of the curve. Let's move on to the item 4.2, which is the Integrated Finance and Quality Report, and we're going to start with Simon. Do you want to kick us off first?
Yeah, I will do. Are you happy that we cover both?
Yeah, cover it all. You cover what you need.
So in terms of 25/6. Call is straightforward in the sense that we hit the plan, and the final accounts all reflect that. And so if I move from there across to Devon, the position hasn't changed in the last 3 months. We reported a position that said we'd be off plan by 64 million, and that was primarily due to the position at RDUH going off by 40 or so million towards in September, October last year, with some offsets, and also as a result of that we lost DCF
support money for half the year. So that bottom line position is 64 million, and that's what's been delivered and confirmed in the positions by each of the trusts in the last month. So there isn't anything else significant to support, and obviously the emphasis is now on, for all of us, on 26/7 and how we improve our position. But I'm happy to take questions, John.
So let's deal with the finance questions first. Anything for Simon on either Cornwall, Arthurshire or Devon? No? Libby, let's move to you, please.
Thank you, Chair. I'll do the same. I'll take the reports as read and just pick out a few key areas for the board. So from Cornwall, Isles of Scilly perspective, urgent and emergency care remains the most significant risk, with all key standards being missed, and particularly a focus around 12-hour waits, the increase around that. I think it's fair to say it's not primarily a demand issue at this point. It's linked to flow and discharge problems as well. Secondly, around elective care recovery, so you'll see in the report that is off track, including 18 and 52-week waits. So that's a real area of focus at the moment. And around cancer performance, we've got a mixed position there at the moment. While we've got 28-day standard has recovered and improved and is above the national target, there are still some areas with key focus around 62-day pathway as well. So those are the key areas at the moment that are the absolute focus areas in terms of delivery that we're working on. From a Devon perspective, you'll see there are performance issues remain across urgent emergency A&E, electives and diagnostic. But we're taking a single end-to-end flow programme approach to that, with an immediate focus particularly around NCTR, because all of those areas are very well connected, with a real focus on unlocking discharge capacity across the system. We continue to see operational pressures that are driving risks, which I'm sure when we come on to quality we'll pick up on areas such as corridor care, mental health and infection performance, but we've got enhanced oversight in all of these priority areas currently. And the other area that I just draw reference to is around diagnostics particularly, and digital programmes, which are a key area of focus for us in terms of making progress. So really some priority work on these enablers, working across with Peter's directorate as well. So those are the key areas of targeted work at the moment, but as you'll see from the report, it goes into a lot more detail around all of the areas of performance, Chair.
Happy to have covered Cornwall and Devon?
That's both, yeah.
And are you happy to have covered it all?
Yes.
Yep. Any questions? Yeah, Graham?
Well, it's not a question as much as a statement, really. I mean, FBQ hasn't met in May by decision. It did look at the likely year-end position in April, and it has indeed landed where we thought it was going to land for the last few months. But I mean, just a statement of the obvious, we have underperformed on a number of services, and yet we've overspent, and we exited the year in terms of workforce 1,285 people over headcount plan. So we've got two things which are actually going both in an adverse direction. Over-resource, overspend and underperformance is not a great entry point into our new year. So there's a lot of catching up to do. I believe it's pivots around productivity. We have looked at what productivity means, but I think there's a lot more mileage to be gained from that. And I know that feeds into SIPs and everything else as well. So.
It's a shame Sam's not here. He's given his apologies, but what would the providers actually say in Devon about that? Because in a summary like that, what's going on? Do we have an answer to that? From a commissioning perspective, do you?
Yeah, so from a commissioning perspective, obviously we are really clear on the expectations and the contracts, which I'm sure Simon will want to come in on. Obviously, there's the enhanced oversight from NHS through the tiering, which is, again, an additional layer of pushing the performance. What I've tried to pull out in the summary is where we feel the areas of focus need to be, and those are the areas that we're working really closely with our providers on to ensure that we start to see some impact. But I think I concur. No, it's the providers. It's the providers, and obviously we would expect through that tiering.
So part of the reason why, Graham, I asked the question, Simon, earlier on, will he be coming back with an answer on this triangulation issues? Is that as we're less of a convener, as we're less of there's no control total now for the system, we can only do this in concert with the provider and region. And therefore we do need some assurance that we're going to have a working pattern with region that's actually going to make sure this is working. Because if not, it's going to be constantly reporting back we're failing and looking to us when we can't performance manage. So we do need to get some written agreement. I think we can have some written agreement too from region. That would be quite helpful in terms of a way of working. Okay. Are you happy you've covered everything off from your seat? Lovely. Thank you. Susan, from your seat, cover both areas. Oh, sorry, bear with me. Did you want to ask a quick? Yeah. Okay. Oh,
he's testing me.
First of all, the ice cream van, and now Neil. What? Sorry.
I know. I've been getting some very interesting texts about the ice cream van, that's called the food van. Thank you, Chair. So if I start with Cornwall and the Isles of Scilly, first of all, for quality and safety, I'll take the report as read. I do think we are talking about how we produce an IPR that's fit for purpose for an ICB, rather than replicating a lot of the work that the providers do and a lot of the reporting that they do. So I think it's very important for us as a strategic commissioner, and I'm talking about that from a quality perspective as well. We have got the new quality framework coming out. My understanding is that will not be the objectives that sit within the national quality framework will not be contained within the national oversight framework, which is a shame. I think that would have been really helpful in terms of getting quality much further up the priority scale. However, we will be working it into all of our quality reports going forward so that it's very clear. So in terms of Cornwall, the Isles and Scilly, I would like to just say a big thank you to CFT and RCHT and our voluntary sector for getting our fractured neck of femur performance into a much, much better place, and that's been recognised by region as well. As we know, our theatre times, from fracture to theatre times, should be 36 hours. To reduce morbidity and mortality. We were struggling to meet that as a target. That is being met. So just an acknowledgement of all the hard work that's gone into that, Chair. It's really important and provides a much better outcomes for our population. I think stroke still causes us some problems, and when I talked about this at the regional meeting, that's causing a problem across, I think, the southwest. It's fair to say this is a whole pathway problem. It's not just an issue that sits with our acute trust. I have highlighted regionally as well that stroke at the moment sits as a Cat 2 mean time for our ambulance service. So that means the standard should be 18 minutes. We know that when we're under pressure, and we have been this bank holiday weekend, where we've seen our Cat 2 mean time go out to 2 hours 40 minutes. So if you're having a stroke, trying to get to your treatment within an hour is nigh on impossible. So I have asked the questions about whether or not nationally that should be reconsidered and pushed to a Cat 1. We do have, I suspect there will be some rationale as to why that isn't the case, but I do think we need to review that again. Very helpfully, region through Vinay Takwal, who's the Associate Medical Director, Deputy Medical Director, has offered some support to come down and help us in Cornwall and the Isles of Scilly with some of our stroke performance and outcomes. But it is a whole pathway. It's not just about the acute trust and the beds. It's also about our community services and getting patients out in a timely way, getting their rehabilitation to get them home very quickly. I think we still have some more work to do around, Libby mentioned it, but I feel this is very much for our providers. Corridor care, it remains high on the national priority agenda. Having worked really hard to get ambulances off the forecourt, in some cases we have shifted the problem into corridors. That is not acceptable for our patients, and I know that the Acute Trust particularly is working incredibly hard to reduce that burden, but it does remain a problem. This is where the work that we've done, particularly in Cornwall and the Isles of Scilly, around services in the community, we need to make sure that we are working hard to use all of the capacity that we have commissioned as strategic commissioners, both in diagnostics as with embedded care. The only other area that I wanted to mention is a piece of work that we're going to do, which I'll come on to Devon, is around maternity and neonatal services. I won't call it a transformation piece, Chair, but there is some work that we need to do around our outcomes for babies and mums on these pathways. In terms of Devon, I think we have areas that remain under enhanced surveillance. Peter will be able to speak more eloquently around the rapid review that was done on mortality for UHP Plymouth, which I understand is improving, as is the quality. However, that stays under enhanced surveillance, and we will continue to monitor that. There is work that's going on around restrictive processes within DPT. Unfortunately, Phil's not here to talk to that, but there is work going on to improve that position as well. And again, we have issues for maternity and neonatal services within Devon, which we will pick up through a programme of work as we go forward. Happy to take any questions.
Brilliant. So before I bring in Neil, this is a perfect moment for me to ask this question. I know I've alerted some of you to this particular point. We've been quite focused recently on the money bit. I think we've got to go through the committees, which is the appropriate place to do what I'm about to say, but I think we need to have an interim report back from you in terms of quality, safeguarding and mortality at the next board meeting, and then probably a fuller report the month after, and that's for Cornwall, the Isles of Scilly and Devon. And I'd ask you to segregate that into adults and children and young people, such that we are completely sighted, but it has to go through the right committees to get there, and some of them will be dealt with and it's not a problem. But if there are issues, we need to be cited on those. So is that okay with you?
Yeah, no, it's timely, as somebody's already mentioned. We've got, I think it was, I can't remember who mentioned it, but we've got the SEND reform plans. All of this triangulates, Chair, so safeguarding, quality, mortality, all of the SEND reforms, it all triangulates, so it'd be good
well, again, when we get
to
to the forward plan, and Helen, if you remind me, because I did ask colleagues earlier on to remind me on the other ones, but can you remind me when we get to the forward plan, at the moment the forward plan doesn't actually have that quality, safeguarding, mortality planned into it for the next couple of board meetings, so we just need to make sure we've got them in, if that's all right.
Yeah, no, absolutely,
okay.
absolutely.
Are you okay with that, by the way?
Yeah, absolutely.
Lovely, because it's a CNO hat on, and you're wearing your Chief Clinical Officer hat as well, I think. Neil.
So thank you. I waited because it was a quality question and I realised you hadn't spoken. I was pleased to see in the Cornwall report that there had been some movement in aspects of stroke care and the neck of femur, and in sepsis as well, which we've regarded as highly important. However, we've been waiting quite a long time, and I think we'd be honest for that. Some of these papers that we've been looking at that provoked concern were from 12 to 18 months ago. So my question is, as we go into our role as strategic commissioners, is where does the phrase expectation on trajectory lie in terms of improvements from providers? And given that we have at the moment 4 main providers dealing with these issues, are there lessons that can be learned by sharing information across providers? And is that part of our role as a strategic commissioner to look at exemplars of work and why they're not being, if they're not being translated in one place, why is that? I know that the problems are multi-system, and I also think that we need to not miss the opportunities, particularly on these issues, to look at our relationship with SWAST. Thanks.
So I'm happy to hear that. So at this point in time, we have 2 system quality groups that we have to run as part of our statutory functions now. We will be bringing that together as one. It's going to be quite interesting to do that, given the size of our geography and the providers that sit within it. But I'm currently working on how we do that and bring that together, because you're absolutely right. The places where we can share good practice, we should be doing so. One of the things that was highlighted yesterday at the regional quality group was the work that has been happening within Cornwall around the neighbourhoods, and they use podiatry, for example, because within that podiatry session that one of the NHS England associate directors came down to, what they saw there was just more than podiatry going on. We were checking people's blood pressure. We were talking about atrial fibrillation. Age concern was in there, talking about cost of living. So, and I think in that one session, 80 people were seen. So we are talking about good practice. But you're absolutely right. We need to continue to share that, but also be honest about those areas where we're not seeing the traction, which is one of the reasons why I raised stroke, because we are not seeing the traction within Cornwall, and it's not because of hard work and diligence. It's just, I think we need to go back around the loop on our capacity and demand, first of all, to understand the root of the problem.
Thank you, Ewan.
Thank you. Really interesting report, Susan. Stroke and the Category 2 decision, that's quite a startling figure. It'd be really interesting to see the impact assessment behind that decision and informing it, because I think there's a challenge there that avoidable deaths and mortality in that first hour, and the inequalities for Cornwall and Devon residents that's actually prejudiced against them because of geography. So I'd really be interested for us as a board to see that impact assessment and see if that decision is justified, or to put pressure on changing to Cat 1.
So it's the very reason I raised it, Ewan, is because, and I think it was brought to mind because I was on call as well, and at midnight was asked what my plans were for 17 ambulances on the forecourt at RCHT, and I asked what the Cat 2 response was. So it's a national decision that stroke is a Cat 2. However, colleagues at NHS England regionally are going to go away and have a conversation with national colleagues. It is something we need our ambulance service to be alongside, but I think the time has come where we should be absolutely lobbying for this. I think the outcomes would speak for themselves, if I'm honest.
So, Helen, I think just for good form, we ought to minute the fact that our Chief Clinical Officer has asked for that, just for your own position and ours. We've asked, because ramifications of this are pretty serious. Yeah.
So can we minute, as Director of Public Health, I have a duty to actually safeguard the health of the population, and I have concerns that a national decision is actually putting at risk the local population as well. So there's the concerns you've raised, but as Director of Public Health, I think it'd be remiss of me not to actually point out this is actually compromising the health system and the health outcomes for residents in Cornwall.
We'll add your commentary to that as well. Okay. Anything else you want from this? No. I'm going to actually turn to Philip, if it's okay. I know Patrick isn't here and he's on holidays. Anything that you would advise in public we have a discussion on workforce about?
I don't think so, thank you, Chair.
Okay, so just take it as it is. It did ask for us to approve some recommendations identified for financial recovery, performance improvement, and the others. So we'll just take that as said. Okay, fine. So thank you on that. The only other point I want to make before we move on there is I'm hoping this is the last time we have this type of documentation. One of the things as a group that we really have to move on to is how do we have more impactful information and less of it, that we can focus on our priorities, because we are still, even though we articulate it and violently agree with each other, whether it be the machine behind the executive group, I don't know, refuses to accept it or isn't briefed to do it, I don't know, but can you please ask that we're going to do this, I'll use it again, pithy, focused reports, and that goes for this type of reports as well. And we have a plan, don't we?
Yes, Chair. So we have agreed that we will have a discussion about reporting, particularly in relation to this type of reporting at the next meeting of the board in private.
Yeah, very good. We must move on. Okay, thank you. So the forward plan. So let me just turn to the forward plan, because I've referred to it a number of times. So this is covering both public and private. I think we need to ask Philippa, to make sure that we cover off the ones that I said I'd need some help remembering. I've forgotten one of them already, but Susan, what was it? What was I asked you to bring back that wasn't on here? That was the interim report and the substantive report on quality and safeguarding. You happy for that to be an interim?
Mortality as well, you said, yeah.
And mortality. So you'll have an interim report with Chris for June, and then the fuller report across children, adults, Cornwall, Isles of Scilly and Devon for July. Is that fine? Yeah.
Okay.
Recognising everyone, August we don't meet, and therefore, June, July are pretty important. What else did I ask for earlier on that was in here? Was it one itself?
You talked about the business plan, but that is reflected.
Oh yeah. Okay, all right. Now there are some big ticket items in here which I just want to draw to your attention. Some of them are the IHO multi-neighbourhood model for Cornwall, so the options appraisal. At the moment, that's earmarked in for September. But that's a decision point. Again, this is an example for me where we've got to recognise we're not meeting in August, and therefore we've got June, July to start to kick that off, gone through it, because we don't want a last-minute exercise. So I think this is an example for me where the executive group, if you can take these away and plot them out, because between now and the July board meeting, which is the last one, isn't that far away? It's like 6-7 weeks away. So there's a lot in that. There's decisions that we're going to want to have in terms of at what point are we going to decide on that we're going to go for moving a cluster to a merger? I understand, Simon, if we're going to do that, we have to have decided. It's a national decision ultimately. It's not us. But you'll need to be ready from getting ledgers ready from the 1st of October to be ready from there. So if you work back from the 1st of October, this isn't going to surprise you. July becomes another decision point from this group to say we'll go for it. Then we have to move into formal stakeholder engagement. That doesn't mean we have to move immediately into it. It just means we start the meter running with an expectation by the board to be ready by the 1st of April. But it has a bigger impact on Simon and you and your team on that. There are other areas in here that I want you to think about in terms of planning, decision for joint committees and that kind of thing. So I think there's a lot of onus on our executive team who are already stretched with the day job. But if you feel you can't do this, this would now be a really good moment to actually say, can I push that back or bring this forward? So Peter, in your space, yes, I'll bring in Neil and then Philip in a second. But we're looking towards having more evidence-based stuff going forward from a population health management stuff. If we wait too long for that, everything else we do is going to be less informed and less empirically based. So there is something for me about, again, the order of some of these things, trying to get ahead of the curve. So please, colleagues, this is not the answer as a document. What I'm asking you to consider is both now, is there anything immediately you feel you want to change, or at very least between now and when we come to do agenda planning for June, if you could feed it into Philippa, and Philippa, you talk to Mark and the team about it, that would be really great. You respond before I
if I could just bring it, so I think it's important to think about this as the first draft of an iterative document that will continue to live and will change on a rolling basis. So we are due to have conversations as executives, as you suggest, John, but also the work that's being underdone in terms of the business plan priorities, which will need to come to the board for discussion, will obviously inform this as well. This has been brought as a first iteration. It will continue to work and develop as we go through the next few meetings as well.
Very good. Neil?
Just two things, please. When we had moved in Cornwall in terms of papers around quality and safeguarding and mortality, and added in the phrase morbidity.
Yep.
And I believe that had got taken up with interest nationally. The fact that wasn't mentioned, does that mean we're moving away from that, or are we going to include morbidity? That's okay. Yeah. That's fine. Sorry to be pedantic.
No. But can we capture that in the minutes too? Because when we talked, when you and I talked about that, we actually mentioned it before we didn't. Yeah.
And in terms of the September meeting, you mentioned a decision on IHO come multi provider for Cornwall. Is that an ultimate decision of a definitive model, or a decision in principle to move towards such models? And if it's the former, will there be time for all parties and stakeholders to have inputted and seen any necessary papers and advisories given? And will we be able to question that has been evidenced by input from multiple stakeholders?
So I think what we can do is give the commitment that we will be working with multiple stakeholders in the way which you describe. I think because of the state of the plan at this current time, I can't confirm the nature of the decision or the timing of it at this point. So we still need to work that through, but we will be in a better place to answer that question following the June meeting and then following the July meeting.
Yeah, and I think at the moment, it's phrased at the moment as an options appraisal. That's not getting to the decision point. It's in a number of instances down here, we've got to measure and manage each other's expectations. If you think about some of the work we did with Price Waterhouse on Devon in terms of re-engineering clinical pathways, I think there was an expectation. That expectation changed and developed as we went through it. I think if we're now looking towards the 3-year plan, particularly in Devon, also of Cornwall, as I said, of course, but particularly in Devon, we've got to work back from that timeline and understand the interdependencies of some of these things. What's the clinical model? What's the governance structure that's going to run it? What are we going to devolve? What's the health bill going to say? This is all the moving parts of the jigsaw I was talking about. If we don't get some of these up front and the appraisal options ready, we actually will be making certain decisions at this point without what we might need to know 3 months later. So some of this is trying to challenge ourselves to have as much as we can up front to be able to know that the order in which we're then going to lay it out. So I would say then, with Mark who's not in the room, it's for Mark then to come back with the executive group to say, this is the list, but it's a different set of headings or whatever else. But if you've got strong feelings, it needs to be earlier, later, or broken down as you say, then will you please get hold of Philippa and feed that in before Mark gets back so that non-execs, partner members, anybody else, if you want to have a view on this and the order of it works, do a download to Philippa first. They can carry that into the executive meeting and then come back with a recommendation to us. I think that's the proper order to do things. Does that work for you? Does that work for you, Neil? Does that work for you? Does that work for you? Very good. Okay. Any observations now? There's enough in there, isn't there? Okay, cool. So we're going to, what are we going to do? Sorry? This bit here? Yeah. And I'm just saying, is there anything else we need to do on this bit here? Yeah, no, fine. Everybody happy with that? Done. Right. So we'll move on to questions from the members of the public. I don't think we've got anybody online, so you rather rudely had my back of my head for a little while, so I apologise. Anything that you would like to ask, or what's on the agenda, of course?
Can I just ask one? Thanks, John. In terms of the out-of-area placements, I understand.
Do you want to come in?
Oh, sorry about that. My apologies.
Introduce yourself as well.
Yeah, of course I will. No, I'll grab this way.
Yeah, just so you can speak into the people online.
Yeah, my apologies, and I'll apologise when we get to so let me start with an apology. So apologies for that. My name's Ben. I volunteer in the local community in Gloucester and lead some national programmes, one of which is how our NHS leaders better connect at a neighbouring community level. So that involved Jim and Penny and Sam, and we were in Newham on the 23rd of February, I think it was. So my question, so I came here to be nosy, if I'm honest, and also my family live in Plymouth, as do a number of my friends, really. So a bit of a context and background to that. When I was listening to the conversation of out-of-area placements, I was really sad, to be honest. And very much like the corridor care, what Jim would say is, how did we get to this? So that was one thing. And the other thing I would offer as a thought, in terms of the mental health, and I know down the far end of the room, some question about the assurance. I sat there and I didn't feel assured for my families and friends in Plymouth, to be honest, really. I heard a lot of the narrative. What I didn't pick up was what those actions and impacts. So again, if Jim was here, what would he say? And I'm not speaking for him, but I guess he'd say, show me the actions. and also show me the inequities built into the action so we don't increase the inequities. Loads more really on my little print stick now. I've been rubbing there. Thank you for the opportunity to come. Thank you and for the opportunity to say a word and whatever. And I think that says something about the culture of this board. So sometimes I go to boards and you just sit there and you're just not even invited to speak and whatever. So think about what that means for the culture of this board. Thank you.
Lovely. Thank you. Susan, anything you want to reply?
Thank you. And yeah, you're absolutely right. It is sad. How did we get to this? However, can I just be clear? The paper that I presented was for Cornwall and the Isles of Scilly. It wasn't for Devon. There was a paper, I think, that was here for Devon that Phil was due to present. Is that right? No?
Not today.
Okay. No. So it was purely for Cornwall and the Isles of Scilly. We had some estate issues in Cornwall and the Isles of Scilly, which needed, and I won't pretend to speak to it because Adi will know far more about it, which meant we had fewer beds in Cornwall. So we saw our out of area placements go up. And because, as I said, of the single sex rules that we have in place in the NHS, unfortunately, it was women that were having to go to out of area placements. I think for some of the reasons we talked about here, we've not seen mental health being given the same priority as general health. I think in Cornwall we've learned our lessons. We've learned some harsh lessons over that, which was one of the reasons why it was a pillar when we looked at all of our urgent and emergency care. We brought mental health into that, and then from that work decided we needed a separate workshop. So the work that we're doing at the moment, as I say, it's in its early stages. We would like to bring back something that gives more assurance, that brings all of the discussions that were had and the agreements made at that workshop, that will allow you to see what we're doing around keeping people out of bedded care where possible so that we can meet their needs at a much, much earlier stage. But just to say, Chair, the paper was for Cornwall and the Isles of Scilly, so I can't comment at this point in time on Plymouth.
Do you just want to... that was the fire-related problem, was it, in terms of the property issue that we had in Cornwall?
So we've got some remedial works.
But that's what it was,
Yeah.
Just so you know what that was. That was a problem that we had that affected the number of beds we had in Cornwall because of a fire-related issue. That was the one you're referring to, yeah?
Yeah. And then just adding to that as well. So the out-of-area placements should be classed as kind of the failure, in terms of we're not dealing with the demand upstream that enables us to use our bedded capacity as a therapeutic intervention.
So as I made the point earlier on, I think the question that I too, on the back of this, would like to just pick up on is where is the Devon equivalent of this on out-of-area placements, just so we're understanding where we're at on that. When do we get that back? It's another example for me on the forward plan. This is a big ticket item. We need to put it in there and say, when's it coming back?
So can I suggest we bring that back to you, Chair? Only I picked this up as a legacy. No. But I picked up as a legacy as part of my old role in Cornwall. I think working with Libby and Peter and the rest of the exec team, we could bring back the equivalent for Devon. I do think anything we do now going forward should be together, not. And apologies, it was a piece of work that we'd carried over from when we were separate ICBs.
So if I could ask you as the company secretary, take this as an item that's not on here. Back into your meeting, make sure it's scheduled in, and we'll make sure it's as part of the journey going forward. Are you comfortable with that? Are you comfortable with that? Are you comfortable with that? Very good. In which case, thank you for that. Right. Is there any other business, colleagues? No, right. So I'm going to give you back 50 minutes of your time. What we're going to do is we're going to start early, because I'd like to try and get a way... I want to use some of their time later on for other things other than the board meeting. So if we can try and finish at 4 o'clock. Are you okay coming back at 1:30? 1:30 it is. Thank you very much. See you then, everyone.
Thank you.